يا جماعة كثير منكم بلش يتجاوز بلش يوصل حد الأعلى للغيابات اللي هو 6 غيابات. هلا اللي وصل 6 غيابات الحين برفع اسمه العمادة ورح ينحرم من دخول الامتحان. احنا بنبعث تنبيه أولي على 4 غيابات وبتخيل أكثر من 9 طلاب وصلهم سو فار تنبيه أولي، وهذا منبر يعتبر غير significant لمسافة الأسبوع التالي. فرجاء التزموا بالحضور والغياب. حضور المحاضرة as important as حضور الراوند. غياب المحاضرة هو غياب زي الراوند بنحسب عليه عليه علامة. للتأكيد الغياب بدون عذر بيروح عليه علامة، غياب بعذر نص علامة. العذر اللازم للغياب للتأكيد شروط قبول العذر يكون من نوع يعني ميديكال سنتر سواء كان برايفت أو حكومي. العذر لازم يتضمن سبب المراجعة، diagnosis، management، وصل مالي لازم يكون برضه مفروض مع العذر، ختم الكز وختم الطبيب، يعني ختم الطبيب لحد ما بكفي، ختم المركز لحاله ما بكفي. أي عذر مش fulfilling هدول الكرايتيريا won't be accepted. فاللي بيقدم عذر مش ينطبق عليه الشروط يكون عارف إن العذر مش مقبول. Today we'll be discussing diabetic ketoacidosis presentation and management in pediatric age group, followed by a lecture about hyperbilirubinemia in neonates and children. Our objectives today to overview diabetes in general, diagnosis criteria, the pathophysiology of DKA, manifestations, and management, and some major complications that you need to be aware of. So most of you, since you've just finished internal medicine education, you know the diagnostic criteria for diabetes mellitus. So you need to have either a fasting blood sugar of 126 milligrams or more, or a rapid blood sugar of 200 milligrams per deciliter or more with signs and symptoms of hyperglycemia, hemoglobin A1C of more than 6.5 or equal 6.5, and or abnormal OGTT test, which is a 2-hour postprandial serum glucose concentration of more than 200 milligrams per deciliter. And we know that the more sensitive one is hemoglobin A1C because it's a reflective of the accumulative level of glucose over a period of 3 months, almost 3 months. So usually diabetic patients do present with common symptoms you all know about: polyuria, polydipsia, polyphagia, and if it's diabetes mellitus type 1, weight loss. So we know that insulin is an anabolic hormone, and it promotes synthesis of protein and glycogen. In its absence, our body will shift towards a catabolic state. That's why patients do present with weight loss in diabetes mellitus type 1. Okay, how common is diabetic ketoacidosis? It's not that common, but it's not a rare presentation or disease. It happens in general. Type 1 diabetes happens almost the incidence 2 per 1,000 persons. However, the incidence of DKA in children is exactly unknown. It's estimated to be between 4 to 8 per 1,000 of all diagnosed patients with diabetes mellitus. It is estimated that in 30% of DM type 1 cases, the first presentation would be actually DKA. So they would present out of, let's say, 100 patients with DM type 1, 30 out of them, the first presentation at which they receive a diagnosis of DM type 1 would be DKA, which sometimes can be devastating and very challenging to deal with. In the United States, the rate is a little bit less than this, so 20% of DM type 1 presentations would be in the picture of DKA. And it's known as the most common cause of morbidity and mortality amongst patients with DM type 1. So as the name or the abbreviation implies, DKA, diabetic ketoacidosis, so we need to have diabetes or increased blood sugar of more than 200 milligrams per deciliter, ketoacidosis and acidosis, and we will review the criteria in more details in a bit. Just to review the importance of insulin in our body, as I just said, so the endocrine part of our pancreas produces insulin at a very steady and regulated rate. At any given point during the day, your glucose level is strictly regulated by insulin. It's very important for glycogen storage or to store glucose in your liver, and to try and decrease the gluconeogenesis in comparison to glycogenolysis. It's also very important to regulate or store glucose in your fat tissue and in your muscle tissue, and it plays a very important role to maintain your muscular mass. Okay, so these are the most common or the most important insulin functions in our body. So it increases the entry of glucose into the muscles and the adipose tissue or the fat tissue, so that in this way, in this manner, glucose levels in the blood will be steadily regulated. Increases liver glycogenesis in comparison to gluconeogenesis. So it stores glucose in the form of glycogen in the liver. It increases glycolysis, which increases glucose utilization when we need it. So when we need extra energy in high metabolic states, for example, this insulin can regulate the production of glucose via glycolysis. It increases lipid synthesis, inhibits glucose production from liver directly, and stimulates protein synthesis and inhibits the protein breakdown. That's why I just said it is very important to maintain your muscular mass. So if you imagine this is our cell, so there is an insulin receptor on top and a glucose channel for glucose entry into the cell. So as soon as insulin molecule binds into its receptor, this will open glucose channels. So glucose will be moving from extracellularly to intracellularly, thus regulating your peripheral blood glucose levels at any time. Okay, so what happens when we have a deficiency in our endogenous insulin? So as we say, the main manifestations would be, or what we're going to review today, is diabetic ketoacidosis, which is referred to diabetes in the presence of insulin deficiency leading to ketosis and acidosis. So if we have got inadequate insulin production, either complete deficiency or inadequate production of insulin by our pancreas, number one, gluconeogenesis process will increase. So there will be upregulation of gluconeogenesis in comparison to glycogenesis, and there would be, in contrary, increased glycogenolysis, so the breakdown of glycogen to produce glucose. Those two processes will lead at the end to increase glucose level in our blood, leading to hyperglycemia. And if we know if hyperglycemia is significant, this will lead to increased osmolarity, leading to osmotic diuresis. So there will be polyuria, excessive urination will lead to dehydration, poor tissue perfusion, and we will be risking our kidneys with prerenal azotemia, or decreased perfusion to our kidneys in case this process was not reversed or treated promptly. Because of osmotic diuresis, there will be renal sodium loss. Some patients will present with manifestations of hyponatremia. Again, there will be peripheral glucose uptake and metabolism, decrease in peripheral glucose uptake and metabolism, again worsening hyperglycemia. As we said, insulin is responsible of regulating fatty acid oxidation. So this fatty acid oxidation will increase or will be also upregulated, leading to the production of ketone bodies, and as a result, acidosis. Acidosis itself will cause shifting of potassium extracellularly, leading to hyperkalemia. But with time, with the continuous diuresis, there will be renal potassium loss. So patients can initially present with hyperkalemia, but with time they can go into phases of hypokalemia. hypokalemia. So we will discuss in managing patients with DKA that we need to monitor potassium levels and correct any deficit. And there will be also renal phosphate loss in our urine. So to summarize, hyperglycemia, hyperosmotic status, hyperosmotic diuresis, increased diuresis, polyuria, fluid losses, dehydration and decreased major organ perfusion, electrolyte imbalance, hyperkalemia or hypokalemia, hyponatremia, hypophosphatemia, acidosis, and ketosis and ketonuria. Okay. Yes, we say that with diabetic ketoacidosis, we need to have high blood sugar readings. However, all international guidelines would always prompt physicians not to ignore the possibility of DKA in the presence of a normal or borderline blood sugar in case patient is actually manifesting with typical symptoms of DKA other than hyperglycemia. So with the absence of a very high blood sugar, but if the patient is manifesting with life-threatening symptoms or suggestive symptoms of DKA, keep it as one possible diagnosis and manage accordingly. Symptoms can include excessive vomiting, excessive thirst, dehydration, polyuria, rapid breathing, fruity smelling breath, nausea, drowsiness, tachycardia, etc. So these symptoms, most of them, as we said, are related to hyperglycemia itself. So we know that hyperglycemia would cause polyuria, polydipsia, unfatigability, nocturia, and enuresis. Again, hyperglycemia can cause vomiting, nausea, anorexia, and abdominal pain. And this will lead, as a manifestation as well, to hyperventilation and deep breathing. We call it Kussmaul breathing as a respiratory way to compensate the metabolic acidosis. So we say that in DKA there will be metabolic acidosis due to fatty acid oxidation, accumulation of ketone bodies, and ketonuria, ketonemia, and acidosis. So our respiratory system will try to compensate by respiratory alkalosis in the way of deep, rapid Kussmaul breathing. Patients as well can present to you with signs of simply intravascular depletion. You might think as a physician of dehydration due to gastroenteritis, but do not ignore the possibility of DKA as well. So many cases we saw in the emergency department were treated as dehydration, as gastroenteritis, and actually they were going through DKA, and we received them in very late stages of DKA. Okay. So don't also forget about neurological symptoms that can be also a manifestation of acidosis. Okay, how we diagnose? So we need to have acidosis, so either blood pH of less than 7.3 or bicarb of less than 15 millimole per liter. And we will classify, we will learn how to classify DKA into mild, moderate to severe according to specific values. Ketonemia, which is the presence of ketone bodies in blood, okay? So we need to measure beta hydroxybutyrate in our peripheral blood samples. However, this is not always, an available or an easy diagnostic to rely on, because the blood tests that we do, our laboratory tests in our labs, they do mainly look for the presence of acetoacetate or and acetone, but not the beta hydroxybutyrate. So therefore, initially, the lab might report back to you saying there is negative ketone. It's not negative, but it's still not recognized by lab tests. So you won't be actually diagnosing DKA because of the absence of criteria. That's why we say ketonemia or ketonuria. So don't rely only on ketonemia to say this is not or this is DKA, okay? Because as I said, there might be laboratory challenges or difficulties in not being able to measure the exact beta hydroxybutyrate level in peripheral blood. So ketonuria can be another diagnostic criteria that we use, +2 and above ketone bodies in urine. So we classify DKA into mild, moderate, and severe according to the level ketoacidosis, or which is basically depending on the level of pH or bicarb level. So if we have venous pH of less than 7.3, but it's more than 7.2, this is mild. If it's between 7.1 and 7.2, this is moderate. If it's less than 7.1, this is severe DKA. For serum bicarb, 10 to 15 mild, 5 to 9 moderate, and less than 5 severe DKA. So once diagnosis, so you need to have high suspicion of DKA, as I just said, not only depending solely on blood sugar level, because as I said, some patients may not actually present with high glucose readings, and you might be facing patients who are not previously diagnosed with diabetes mellitus type 1. So you need to have a very high suspicion of DKA if the patient is presenting with the symptoms that I have just mentioned. Extra questions or extra diagnostic criteria or extra clinical manifestation that you need to look at include the level of consciousness, which is very important, because we will talk later that one of the complications of DKA essentially and acidosis, and it can be also a complication of our clinical management in the emergency department, is cerebral edema. So assessing cerebral edema risk factors or manifestations is very important. So you need to assess the level of consciousness, the Glasgow Coma scale. You need to measure full vital signs at baseline, and if the diagnosis is made, we need to regularly keep checking on the vital signs. You need to rule out or to look at any factors that might exaggerate or exacerbate or worsen the prerenal azotemia or the decreased perfusion like vomiting. You have to assess precisely the degree of dehydration, and you have to have a strict input and output chart once a patient is admitted, because we know how much fluid is being taken and how much is the kidney or the kidneys are able to excrete. Okay. In pediatric age group, triggers to have DKA mainly, or one of the common triggers, are infections and infection stress, oxidant stress that we see in infections can trigger DKA, specifically in patients who have no previous diagnosis of DM type 1. So think of DKA as well if the patient is presenting with fever, hypothermia, hypotension, refractory acidosis with no explanation that can't be corrected with the regular methods of acidosis correction, and the presence of significant lactic acidosis. So the classic blood workup that we need to do: random blood sugar, of course, blood gas, usually peripheral capillary or venous blood gas, to measure pH and bicarbonate level, sodium, potassium, urea, and creatinine, because we say that complications of DKA include electrolyte imbalance like hyponatremia, hypophosphatemia, hyper or hypokalemia, and prerenal azotemia can lead to abnormal kidney function tests. Measuring ketone in blood or urine, and again, if you suspect an infection as a trigger for the DKA, if the patient is febrile or showing signs of sepsis or infection, you have to do a sepsis workup according to the symptoms the patient is presenting with, like chest X-ray if respiratory symptoms, for example, CSF, throat swab, blood culture, urine analysis and culture, etc. So, general rules of therapy, and these rules should not be different between different centers. So these are the most, the rules that have the most consensus about between most international centers and guidelines. First of all, kids with DKA as a presentation should never be managed in a regular ward. So they need to admit it to a pediatric intensive care unit. Number two, we have to assess the hydration level and correct the hydration, yes, promptly, but very, very extremely cautiously, because we don't want to complicate DKA with cerebral edema if we do reckless or rapid fluid collection or fluid resuscitation. Usually we start patients on IV insulin, and we can't at this point, if the patient is just diagnosed with DKA, we can't say need to continue subcutaneous insulin. No, because we need to have specific rates and specific dilutions in specific ways, and we'll have to monitor the response and fiddle around the level of insulin very cautiously and very slowly. So we discontinue or disconnect sub-Q insulin and start on IV insulin. Initially, if the patient is presenting to you with signs of dehydration, especially if the patient is clinically severely dehydrated, or if the pH less than 7.1, if bicarbonate is less than 5, which indicates severe DKA. So as a conclusion, this would be associated by severe dehydration. You need to give boluses for intravascular fluid expansion, okay, or for intravascular depletion. Boluses usually are of normal saline, 9% sodium concentration, and we give 10 cc to 20 cc per kg. And we will show you later on how to specifically calculate fluid maintenance and deficit for DKA patients, and what special precautions we need to follow. So the reason why we emphasize on the importance of dehydration on the evaluation of dehydration status and to promptly manage dehydration if present and if severe, because we need to promptly restore the effective circulating volume by giving acute replacement to replace some of the water losses and the sodium losses. We say when we go into DKA, there would be excessive urination and excessive free water losses. We call it free water, and sodium losses. So we have to replace what lost the dehydration degree is severe by giving boluses, and also enhance the glomerular filtration rate, because if the kidney is struggling fluid, so there's no pre-renal fluid reaching to the kidneys, the glomerular filtration rate will be affected. And if the glomerular filtration rate is affected, you can't clear glucose from the body, and you can't clear ketones from the body. So we need healthy kidneys to be able to recover from DKA, to get rid of ketone bodies and to get rid of excess glucose. Because we know excess glucose needs healthy kidneys to be excreted by urine. It's the same for ketone bodies. So ketonemia or ketone in blood, you need healthy and healthy kidneys to excrete ketones out through urine and to get out or to overcome the acidosis status in DKA. Okay, so how do we calculate fluid management in a patient with DKA? So simply, the patient is dehydrated, we have to calculate deficit and maintenance fluid. However, I need to just notify you that fluid management in DKA, the way we calculate maintenance and deficit is much different to the way we do calculate fluid maintenance and deficit for someone who's presenting to you with dehydration secondary to gastroenteritis. So it's different. أخذتوا محاضرة الفلويد management. So you will notice there are differences between fluid management here and the way we calculate fluids and the way we calculate fluids for other pathologies like gastroenteritis, for example. Because as I said, in DKA we tend to be very cautious. So we calculate the minimum needed amount of fluid to deplete the intravascular circulation and to maintain a good glomerular filtration rate. Okay? So we assume, the degree of dehydration, okay, is what judges the percentage of deficit that we're going to calculate. So if the patient is presenting to you with mild to moderate DKA, so a pH of more than 7.1 or equals to 7.1, we calculate a deficit of 5% of the body weight. However, if the patient is presenting to you with severe DKA, so the pH is less than 7.1 or bicarb less than 5, so we need to calculate a deficit of 10% dehydration. So This calculated volume of deficit needs to be the rate that we can. So we calculate a volume, صح? And we calculate a rate, صح? So let's say a liter over 24 hours بيطلع معنا rate, صح? Right? مش هيك أخذتوا محاضرة fluid management. So we need to have a certain amount of mils per kg per hour. هذا اسمه fluid rate, صح? When we calculate deficit volume in DKA, so we have the volume, but we divide it over a period of 48 hours, not over a period of 24 hours. So double the duration. Why? As I said, because we need to be extra slow and extra cautious managing fluid for patients with DKA, not to induce or cause cerebral edema, which can be a complication of DKA and acidosis itself, but also can be iatrogenic, caused by us if we rapidly correct fluids. شباب وصبايا بالنص. Is a interesting talk يعني share it with us please. صبية لابسة أزرق واللي جنبك. This is very disrespectful على فكرة. Okay. So what type of fluid should I choose when managing dehydration in DKA patients? So usually we choose normal saline 0.9% sodium chloride without any glucose added to fluids. So when the patient first presents to us, we choose fluid preparation without glucose. And as the patient is recovering, when the patient reaches a reassuring level of glucose in blood, peripheral glucose reading, and when the patient is starting to show signs of recovery out of ketonemia, we start to gradually add glucose to fluids. But initially, it's without any glucose, okay? So when the plasma glucose is, let's say, falls down below 250 milligram per deciliter, this is where you can add glucose to your normal saline fluid. Now, as I said, patients with DKA due to excess water losses, and they might initially present with hyperkalemia due to acidosis. صح؟ acidosis بيعمل shifting of potassium من intracellular extracellular, صح؟ هاي the effect of acidosis. So they initially might present with hyperkalemia, but with time, with fluid losses, there would be hypokalemia. So according to the level of hypokalemia the patient has, we add potassium to the total fluids per day. So if potassium is less than 4, we add about 60 milliequivalent per liter of fluid. If potassium level is between 4 and 6, we add 40. If it's above 6, we don't need to add extra potassium to their fluid maintenance. Okay, how to calculate maintenance requirement? Again, this is very different from how we calculate fluid maintenance in other conditions. Because I will get questions later on saying, we had a lecture about fluid calculation and it's much different than this. Yes, as I said, we use the lower than standard fluid maintenance. This is what we call it, the lower than standard fluid maintenance volumes, okay? So if it is mainly weight dependent. So if the patient is less than 10 kilograms, we give 2 milligrams per kg per hour. So this would be the maintenance rate. If the patient weighs between 10 and 40, we give 1 ml per kg per hour. And if the patient is more than 40, we give a fixed volume of a fixed rate of 40 ml per hour. Okay. We said initially, if the patient is presenting to you with severe dehydration or severe DKA, so you'd expect that the patient has severe intravascular depletion, you start by giving a bolus of fluid resuscitation of normal saline between 10 to 20 ml per kg. However, sometimes you might need to give more than 20 ml per kg. Okay, sometimes it's given for so many other reasons. So if you have, for any reason, to give more than initial bolus of more than 20 ml per kg, you have to subtract the additional mLs per kg out of the total fluid calculation over a period of 48 hours. So if I gave my patient in the emergency department when I first diagnosed him 30 mils per kg bolus, so up to 20 is fine, the extra 10 mils per kg, so if the patient weighs, for example, 10 kilograms and I give extra 10 per kg, so 10 by 10, 100 mils, I give a total of extra 100 mils. I have to subtract this 100 mils out of the total volume I've calculated to be given over a period of 48 hours. We don't give in pediatric group sodium bicarb replacement, even if the patient has severe DKA, if the bicarb level is very low, less than 5. We don't give sodium bicarb replacement. This can lead to very life-threatening sequelae and can increase the risk of cerebral edema. It might be the practice in adults. I think in adults they do give bicarb replacement in an emergency department setting and in general in managing DKA, but we don't do this in pediatric age group. Okay, so as we say, the hourly rate is the deficit volume over 48 hours combined by the maintenance rate that we have just reviewed. So let's take this as an example. So a 20 kg, 6-year-old boy has a pH of 7.15 and had initially a 10 cc per kg chloride bolus. How to calculate his fluid requirements, both maintenance and deficit. So 7.15, so this is more than 7.1. So this is not severe DKA by definition. So we calculate a 5% deficit. Okay, so this is considered mild to moderate DKA. So 5% deficit should be enough. So 5% by his body weight, which is 20 kilograms, will have 1,000 mils. This is the total fluid I need to give over a period of 48 hours, so not 24 hours, okay? So 1,000 mils divided over 48 hours, so the rate for his deficit alone would be 21 mils per hour, okay? And according to the weight-dependent maintenance fluid rate, because he's 20 kilograms per kg, he will have 20 mils per hour, okay? So we combine 20 ml per hour of maintenance plus 21 ml per hour as a deficit, so we'll have 41 ml per hour as a total rate to be received, okay? Another example, so a 60 kg, 16-year-old girl with a pH of 6.9 who has given 30 ml per kg of normal saline as a fluid initial bolus for circulatory collapse. How much fluid will she require? So again, the deficit, so she's presenting with severe DKA, pH 6.9. So we will need to treat as severe dehydration. So the deficit would be 10% per body weight. So 10% multiplied by her body weight will be 6,000 mils. But initially she received extra bolus than what we usually calculate. So we say any amount of bolus that exceeds 20 ml per kg needs to be subtracted from the total deficit volume. So she received 30 ml per kg. We're fine up to 20 ml, so we have 10 ml per kg extra resuscitation fluid given, which is 10 multiplied by her weight, 60. So 60 ml of extra fluid was given initially. So we subtract this 60 ml from the total deficit, so 6,000 minus 600, and then the result will divide over a period of 48 hours. We'll have 113 ml per liter as deficit rate, and the maintenance rate, it would be fixed because her body weight is more than 40 kilograms, so 40 ml per hour as a maintenance, and we combine both, we'll have 153 ml per hour. This is her total fluid correction rate over a period of 48 hours. Okay. As soon as we start managing DKA patients, we need to start them to discontinue their sub-Q insulin, either the sub-Q insulin pumps or needles or whatever route of sub-Q insulin they're having. So we discontinue any sub-Q insulin and we start insulin infusion around 1 to 2 hours after the initial fluid resuscitation was given. So usually the dose of insulin can be basically anything between 0.05 to zero point 0.1 unit per kg per hour. So the minimum is 0.05 and the max is 0.1 unit per kg per hour. So how do we choose? So this is a very wide range. So how do we choose? So studies found that patients who are presenting for the first time in a state of DKA, so if this is the first presentation, they tend to be what we call insulin sensitive. Okay, so they will respond really promptly to any exogenous insulin or any insulin replacement. So we tend usually for those to start with the minimal rate of insulin. So we choose the minimal rate of insulin. So we start with 0.05, for example, and we gradually increase or decrease according to their response, according to their blood sugar readings, according to their clinical improvements and laboratory improvements. We don't give insulin bolus. Again, this is one another difference between managing DKA in pediatric and adults. In adults, they do give insulin boluses in emergency setting. In pediatric, it's a no-no. Again, rapid correction of hyperglycemia can also lead to increased risk of cerebral edema in pediatric age group. This is what most studies have agreed on. So we don't go give boluses of intravenous insulin. Okay, so when we give insulin as infusion, what we do is we will start by what's called suppression of hepatic glucose output. Okay, and as a result, we would suppress ketoacidosis. Okay, again, because we're given insulin, we will stimulate the peripheral glucose uptake and metabolism, and this will lead to reverse the hyperglycemic state and decrease the level of hyperglycemia, and as a result, improve acidosis and improve ketosis as well. We've mentioned this. Okay, so adding dextrose to intravenous fluid, we said initially we only give normal saline fluid with no glucose. However, if the patient hyperglycemia is being corrected and if they reach to a level where their serum glucose concentration is below 250, some centers say below 300 milligram per deciliter, or the rate of decrement, if you notice. So we plot blood sugar readings on a chart. So if the decrement rate is more than 100 milligram per deciliter per hour, this is alarming. Okay, as I said, we don't need to have rapid drop of glucose level. Rapid drop or rapid correction of hyperglycemia will increase the risk of cerebral edema, and we don't want that to happen. So if we notice a rapid decrease in glucose readings, more than 100 milligram per deci per hour, or blood glucose concentration drops to less than 250 or 300 milligram, we start adding dextrose to the total fluid volume. When do we stop IV fluid therapy? If ketosis is resolving, so there is no ketone in blood or negative ketone in urine or less than +2 in urine. If the patient is conscious, glycemic score is normal, if he's alert, and if the patient can maintain oral intake, so there's no nausea, no vomiting, etc. When the patient is admitted with DK, as I said, we never admit them to a regular ward. The reason behind that, simply, because a patient with DKA needs strict monitoring of their vital signs and regular blood sampling, and this can't be done in a regular ward. So in wards, they usually do vital signs every 4 to 6 hours to patients admitted. However, initially, a patient with DKA, we need to measure their vital signs every hour, sometimes more than hourly if there's any disturbance in their vital signs. So we need to regularly test their glucose reading and plot them on a specific chart to review the decrement rate. We have to plot their full vital signs, everything like O2 sat, blood pressure, heart rate, respiratory rate. We have to also have a strict input-output chart. Everything the patient has, like their total IV fluids, or if there's any oral intake, and how much output they maintain. So usually we give them urinal to urinate in, and we measure how much urine output they have, and regular check on their level of consciousness or the modified Glasgow Coma scale. After we have started the DKA management, after we have started their IV fluid and their IV insulin infusion, every 2 hours and then every 4 hours, so the rate of strict monitoring will be less. So instead of hourly, then we move to every 2 hours and then every 4 hours of measuring their glucose, blood pH and PCO2, electrolytes and ketone bodies. Okay. The patient should be evaluated face to face. So if you are the doctor on call, it's not enough to call the nurses and ask how my patient is doing. You need to see the patient face to face at least every 4 hours. Some centers would say every 2 hours to be evaluated by a physician. Specifically, more frequently sometimes, if the patient is less than 2 years of age, or if they initially were admitted of severe DKA, so the initial pH is less than 7.1, you need to see them more frequent than every 4 hours. Each time you see DKA patient, you assess them, you need to comment on their clinical status, are they conscious, alert, oriented, the vital signs, the neurological status is very important, because you need to be very vigilant to any early signs of cerebral edema, like drowsiness, if they are confused, if there's any abnormal neurological signs, seizure, etc. Sometimes we need to do ECG for specific patients. Result of blood investigations have to be reviewed by you. Don't depend on the nurses to tell you, yes, I checked the kidney function test and it's normal. You have to check the results yourself, and you have to also check the input-output chart. This is how the chart looks like. So it's very precise and very detailed. It has everything. As you can see, the vital signs in details, glucose level, pupil size on both sides, because this can be an early sign of cerebral edema. If there is discrepancy in pupil size, or if the pupil is, for example, dilated, non-responsive to light reflex, you have to also check the capillary glucose level, capillary ketone, any IV axis needs to be also documented. Insulin rates, at what rate you're given insulin each time you evaluate them, levels of electrolytes, pH, etc. Okay. If ketone levels fall down to less than 3 millimole per liter, first of all, you need to continue using sodium chloride solution, but you need to add 5% glucose, and you need to add extra potassium per 500 ml. And you have either to reduce or maintain an insulin diffusion rate on the minimum rate, which is 0.05 units per kg per hour. And this is different to whether the ketone levels are above 3 millimole per liter. If it's still above, so if you follow up the patient, okay, clinically is well, but the ketone levels are still high, more than 3, you maintain insulin rates between 0.05 and 0.1 units per kg per hour to try and switch off ketogenesis. And you need to change your fluids into 10% glucose rather than 5% glucose to prevent hypoglycemia, because we increase the insulin rate, right? We need the insulin effects on ketogenesis, but we don't need the rapid correction of hyperglycemia. We don't need the rapid drop of glucose levels secondary to increasing the insulin rate. So yes, we increase the insulin rate to switch off ketogenesis, but we add extra glucose to our fluids. So instead of using 5% glucose, we use 10% glucose. After you have managed your patient, the patient is very well, glucose levels are all within, dropping down to less than 300 milligram per deciliter, ketones are less than 3, the patient clinically is great, no electrolyte imbalance. You stop, before you stop the IV insulin infusion, you need to restart the patient on his pre-admission sub-Q insulin at the same doses, and then give him at least a bridging period of 30 minutes, and then you stop the IV insulin. Why do we treat patients with DKA very cautiously? And the answer is very simple, because it's the leading cause of fatality and mortality amongst kids with DM type 1. Kids can die really quick from DKA. The most feared complication of DKA is cerebral edema. Okay, it's not very common. So about between 1 and 5% of DKA cases can develop cerebral edema. So out of 100 patients with DKA, maybe up to 5 can develop cerebral edema. It's not that common, but it's very significant, and it's a very preventable cause of mortality. Mortality out of cerebral edema. So if the patient develops cerebral edema, mortality rate is really, really high. Quarter of the patients would die. Usually, the manifestations of cerebral edema start within the first hours after the initiation of DKA therapy. So 6 to 12 hours most of the time, so less than a day. And usually patients, they show significant signs of improvement. The reason behind that, so when the patient is very dehydrated, paraglycemic, and you give them excessive fluid station, initially, the patient will significantly improve because you are repleting their intravascular depletion and you're correcting their hyperglycemia. But as we said, quick or rapid correction of dehydration and hyperglycemia will significantly increase the risk of cerebral edema. So after 6 to 12 hours of your initially successful treatment, the patient starts to deteriorate gradually. So risk factors for cerebral edema: who are the patients at higher risk to develop cerebral edema? If they initially have high blood urea nitrogen concentration, so more pre-renal azotemia or pre-renal or intravascular depletion leading to pre-renal insult. If they initially presented with a very low PCO2 in the venous blood gas, and if you correct their hyperglycemia, however, serum sodium fails to respond. So we say that hyperglycemia will lead to, and the diuresis will lead to hyponatremia. So if you correct the hyperglycemia, but hyponatremia is still a problem, this also increases risk to develop cerebral edema and initial treatment with bicarbonate. That's why we don't advise on treating patients, pediatric age group, with bicarbonate. How do they manifest early? So initially they might complain of headache, which can be ignored sometimes, agitation or irritability. So if the behavior of the child changes in any way, unexpected fall in their heart rate, because cerebral edema will affect the autonomic nervous system and then affect the heart rate, and if they have increased blood pressure as well. So these are the early manifestations, but the red flags, the more important manifestations of cerebral edema indicating well-established or a more severe degree of cerebral edema include deterioration in the level of consciousness, abnormal breathing pattern like respiratory pauses or what we call them apneas, oculomotor palsies, pupillary inequality or dilated pupils, fixed dilated pupils or decreased pupil response to light reflex. If you suspect cerebral edema, this is an emergency. You have to inform the consultant, the most senior consultant. You have to quickly try and correct the situation. You will give mannitol as the first management step. So start mannitol 0.5 to 1 gram per kg kg over a period of 10 to 15. So it's considered somehow a quick infusion of mannitol. And we give hypertonic saline to reshift fluids from the brain tissue, right? So we give hypertonic sodium chloride at a concentration, usually we use a 3% concentration, 2.5 to 5 mils per kg over, again, a period of 15 minutes. Hypokalemia, as we said, usually patients might initially present with hyperkalemia, but with time and with years, they might have hypokalemia in different degrees. So if potassium level is very low, less than 3 millimole per liter, we might temporarily suspend our insulin infusion. Because did you have any lecture about managing hyperkalemia? So we always say correct acidosis, right? We correct acidosis, and insulin is one important part of managing hyperkalemia, because insulin will lead to shifting potassium from extracellular space to intracellular space. So if the patient is significantly hypokalemic and it's not being corrected by your classical management of DKA, we might think sometimes of stopping the insulin infusion, and of course need to have a special critical care specialist as well with you, because sometimes we need to have a central venous catheter inserted if we need to give extra intravenous infusion of potassium above 40 millimole per liter. Because if potassium extravasates, what will happen? So if you're given potassium at a high rate through a peripheral cannula, what might happen that the cannula will not hold this high rate of potassium. There might be extravasation, يعني إذا الكانيولا طلعت من مكانها, and this might lead to significant burn, skin burn, okay, and other complications. So sometimes if we need to give high levels or high concentrations of potassium infusion, we might need to insert a central venous catheter, like a femoral line, for example, to give the patient the proper potassium correction. If the patient is presenting to you with vomiting as a manifestation of DKA, we have to insert an NG tube to do like what we call gastric decompression and to decrease the likelihood of aspiration, specifically if the patient has depressed level of consciousness. So with DKA, some kids might present with persistent abdominal pain. And this is a normal or a common manifestation in kids with DKA due to liver swelling. Sometimes gastritis can cause abdominal pain, specifically what we call stress gastritis. So patients with ICU should always be on PPI, proton pump inhibitors, to prevent stress gastritis. Sometimes they might have urine retention, bladder retention leading to abdominal pain or ADS. Again, a kid with DKA can as well have a surgical emergency. Unlucky kids with DKA can also have appendicitis, so don't ignore the possibility of a surgical abdomen if a kid with DKA is having significant abdominal pain on physical examination. Also, patients with DKA can still have persistent increase in amylase levels that last for a few days after treatment. How to avoid future episodes of DKA? Counseling is very important. So specifically for newly diagnosed patients with DM type 1 who are presenting to you as DKA, you have to sit with the family, talk them through DM type 1, its complications, prognosis, and how to keep their glucose levels under control, okay? And what red flags they need to notice on their kids, not only polyuria, polydipsia, and weight loss. So they need to be cautious about any abnormal breath smell, like acetone smell, decrease in activity, agitation, headaches. All these red flags need to be discussed with the family, and they need to know the importance of therapy adherence. They need to adhere to the sub-Q insulin that we're going to describe as outpatient treatment. We always ask them to leave or to write a diary, So each day they will need to have specific reading. For example, 30 minutes pre-prandial or 2 hours post-prandial, and to record the readings, because we need to fiddle or adjust their insulin levels based on the readings. And this is the mainstay of managing a kid with DM type 1, is to keep their blood sugar under good control. Thank you very much. ناخذ